there's a link up on our Facebook page. You can kind of put them in. A new society that basically aims to expose you to the specialty of sports medicine, give you kind of opportunities in terms of research and shadowing opportunities, and also with educational elements, muscular
So we've had a few events this year already. We had our concussion one, we had our introduction to what is sports medicine earlier in the year, and then just a couple of weeks ago had one focused around nutrition. And so then we're moving on to more of our exam sort of based activities. And so then we've got some activities now. We also have a shoulder one coming up later in the year. So then we thought effectively for 6 years your exams come before the shoulder one. So feel free to ask any questions related to that that you might have as well. And then as an ongoing thing going into next year as well, as they sort of alluded to already about the opportunities that we're going to set up in terms of clinical research and elective databases, which then if anyone has any sort of interest in these areas, they can come and ask us, and we'll have a bit more of an idea of interested doctors that are willing to work with students for research or just have cities in their clinics today or that sort of thing. And so we can help with establishing those sorts of contacts for you to get more education in sports and exercise.
And so, without further ado, I'd like to introduce Dr. David Humphries. He's come all the way from Tasmania for this talk. He's an ex-US student from, I believe, 1981. Is that right? Yeah. And he's got a wide range of things to consider. He's very abridged, including being ex-president of the Australasian College of Sports Physicians, chief medical officer of MFA in Tasmania, medical officer of AFL in Tasmania, and also cricket. So if we can give him a warm welcome.
I only found out about this society through one of our registrars late last year, and I thought, damn, that's a really good idea, because when I went through med school, sports medicine didn't exist. And in fact, when I went and talked to people after I graduated, they still told me sports medicine didn't exist. And I decided that sports medicine did exist, and so that's kind of what I've been doing since 1984. But I have to congratulate on being interested in the field, because it's one of the areas of medicine that is still wide open, both in terms of jobs, in terms of research, and in terms of new careers to be created. We haven't even touched the sides on what physical activity can do in humans. So yes, I did come through here. I did actually, that's really nice. You've got new buildings. I climbed the outsides of most of the old buildings when I was here. We used to have a society that liked climbing buildings. Usually very early hours of the morning. It wasn't entirely legal then, it's probably still not. So just to kind of run through my background a little bit. I left here in 81. I'd done my training at St George, so I went to St George as an intern and a registrar. I was actually very interested in preventative health when I came through my training, and then I discovered that there was only one professor of preventative health in Australia, and I thought it may not be a great career path because he was not that much older than me. And so I went off and I actually trained as a rural GP, and that included doing dip obs and various other bits and pieces, and it actually served me very well through sports medicine. In 1984, I came back to Sydney briefly, and one of my old colleagues from university days, Jenny Saunders, had established a clinic built around looking after St George Rugby League. And Jenny heard I was back in town and knew that I'd done a fair amount of training in orthopaedics, and I quite liked musculoskeletal stuff. And so she said, look, I've got a 6-month post, And here I am 30-something years later, still doing the same thing. The College of Sports Physicians was actually founded in late 1984, and in 1991 they held their first fellowship exams. So they put together an external board of censors made up of rheumatologists, orthopaedic surgeons, occupational physicians. And there are about 40 of us around the country who were granted a fellowship. It took us another decade and a half to actually get taken seriously as a specialty group, but it's been a fully fledged specialty for 6 or 7 years now. I was actually the chair of the group that finally managed to get us through the AMC accreditation process. I've had about 10 years on and off as the chief of examinations, the censor-in-chief for the college, and I've had a stint as president of various other things, and I'm happily retired from all of my college duties as of February this year. I've got particular interests in physical activity, on human health, and that's not because I'm a researcher. I just find it interesting that there's all of this stuff that we can do for health, which most of us don't do as doctors. And I know all of you aren't going to be sports physicians, but there are really very few branches of medicine where physical activity doesn't have an impact, a significant impact on the health of your patients. Perhaps forensic pathology, it's not going to be all that great, but most of the other fields of medicine, you will find some part of physical activity that can assist you. And I've got to say that people actually like to be told and given some advice about how to exercise. So, brownie points for anyone who knows the quote. It's one of the privileges of old doctors. We get to stick up stupid quotes and expect you to know what they are. St. Augustine. So walking solves it. Walking solves a lot of things in life. If you're trying to figure out a problem, doing something like going for a walk is quite useful. My main love in terms of exercise these days, can we turn the front lights now a bit, is bushwalking. And so you'll see lots of bushwalking slides along the way here. Yeah, I'm not sure. Yeah, I'll just this. I'll just have a this is up on the Duquesne Range in Tasmania. At the moment, there's about 3 metres of snow up there. So walking solves it. It's a good principle. So I'm going to ask you a couple of questions. Why should we exercise? So you all know about health risk factors and disease and what have you. I want to pick one in your head right now. Okay? Pick your disease or pick your risk factor. Now, I reckon some of you will have chosen smoking, diabetes, obesity. How many chose low physical activity? Okay. Do you know what the biggest risk factor? All-cause mortality? Low physical activity. Okay, so let's invent a new disease. Actually, it's not new. You'll see it sitting around outside of outpatients in some of the hospitals. We'll call it smoker diabetes. Right? It's the worst thing you can possibly have in terms of risk factors. They hang around outside the vascular ward because they've already had one leg off and they're just waiting to lose the other one. You know what? That's a bigger risk factor than having smoker diabetes. Let that sink in. Low physical activity levels is a bigger risk factor than smoker diabetes. So some of the basic reasons we want to exercise, we know that it improves quality of life. It does improve duration of life a little bit, but probably only a couple of years. But quality of life is important. I certainly am becoming much more aware of where quality of life has taken me because I don't really want to end up in a nursing home. And if I end up in a nursing home, I certainly don't want to be pushing one of those stupid trolleys around in front of me. Okay? If I am physically fit, then I'm less likely to be in that situation. It has an enormous amount of influence on most it's not, but it costs about a quarter as much as any other sort of interventions. And it's very safe. It's actually quite hard to kill people with exercise. I mean, you can do it, but even if I've had an infarct a month ago, provided my angina is pretty stable, my risk of dying of the infarct from exercise is only about 1 in 100,000. So, you know, it's quite hard to kill people with exercise. So the Australian activity guidelines have been changed in the last year or two. And they used to just say 30 minutes per day. But now we've got this sort of 150 to 300 minutes per week. We get to accumulate it. There's certainly good, strong evidence that we can accumulate it in small bits. It doesn't have to be half an hour all at once. You notice they've said, or you can just do 150 minutes of vigorous exercise. And that's because of some of the studies, the long-term epidemiological studies like the framing study and the physician study in the States, so that we know that intensity, so increasing the intensity of activity, increases the health benefit out of it. But it doesn't mean that you've got to burst a full valve trying to run marathons all the time. The level of physical activity is not that great. What they don't really say in this is that for your first 30 minutes a day, you get about half of all of the health benefit that you can get. And for your second 30 minutes, you get about 90% of the remainder that's available. So 30 minutes is our kind of, this is what we should be getting the population to do. But if we can persuade people to do more than that, then we almost double the amount of benefit that's available. How many here do 30 minutes a day? Okay. Anybody do an hour a day? It's good, but it's 1 out of 50. Yeah. And you're in the healthy age group. Believe me, it gets harder as you get older to be enthusiastic about trying to do an hour a day. A good friend of mine, Karen Khan, who out of Bruckner and Khan, the textbook on clinical sports medicine. Karen tried really hard to do an hour's activity every day for a year. And Karen is one of the most obsessive people I know, and he managed 363 days. It's not easy. So public health implications of physical activity. So at the moment, it's costing 4 times the annual Medicare budget in terms of physical inactivity. And that includes time away from work because of injuries that could be prevented, illnesses that could be prevented. These figures are about 4 years old now, but you know, 200,000 people a year moving from the overweight range to the obese range. I suspect the cost of a diabetic patient is enormous in medicine because it's system-wide. We get organ failure in a whole range of things, and they don't die quickly. It's the whole problem with the NCDs is people don't die quickly. It used to be great. You get an infection, no cost to the health system. But now we don't die quickly. You do realise we spend 15% of the entire health budget on people in their last week of life. It's not a great spend of money. It is if you're the patient, but not a great spend of money. So, you know, at least 20 of the most common NCDs are influenced by physical activity. Either we can prevent them, we can treat them, or we can modify the course of the disease. Now, you might think that NCDs are really a Western problem, but in actual fact, the NCDs are a bigger problem in developing nations than they are in the West. because they have less facilities to be reactive. I taught in a place, a tiny little island called Palau, which is sort of north of New Guinea. It's a country of 20,000 people. They have 5 doctors in Palau. When I was teaching there, they told me that they had declared a national health emergency, which was really around the NCDs. You know, a country of 20,000 people does not have a lot of funds to look after a population. So it's not just the West that's afflicted, it's the developing nations. So only about 25% of Australians, maybe 30% if we're being generous, actually achieve the minimum daily activity levels. Now, in one of Bill Bryson's books, Bill Bryson's a travel writer, I've never actually hunted down the original reference. He says that the average American's total daily exercise now is 300 metres of walking. Now, that's close to true. We're in a pile of doo-doo. Okay, so how's all of this front out? You know, why do we have to be active? And it probably runs back to the genome that we're running. We're really running 50,000-year-old software here. You know, just because we're modern doesn't mean that our software is modern. And I know this is a very wordy slide, but what we're really saying is that environmental factors exert an influence on subpopulations of genes. And when that passes a threshold that's biologically significant, then we get the expression of a disease. And you go, well, how's that happen? Because genes are programmed for survival. Yes, they were programmed for survival 50,000 years ago, not last week. So we're still dealing with the environment that was 50,000 years ago. So in humans, that sort of inactivity-activity threshold, it's biologically significant because it leads to epigenetic switching. So everybody's happy with epigenetics? I'm not. So I think it's the Cold Harbor definition, basically says that we've got a phenotypically stable change without genetic alteration that can be passed on. And epigenetics is really the study of what environment does to the various switches on our genes. And the research in exercise medicine is still in its infancy, but there's a paper from Volker and Ross that looked just simply at the effect of physical activity on the genes that control fat cells, adipocytes. What they found was that there are at least 35 candidate genes working on both obesity and diabetes type 2, which are switched on or off by physical activity. And it's a sort of a blanket process. They methylate all of these genes. So that's just looking at adipocytes. They found 35 candidate genes just with 6 months of physical activity. So I'm certain that when we delve into this stuff a bit more, we're going to find that there are an awful lot of things that switch on and off in humans that are related to physical activity. So in humans, inactivity is really an abnormal event for a genome that's set up to be active. You know, we were supposed to be running around the Serengeti, running away from lions, running towards buffaloes, that sort of stuff. So animals certainly know that. If you put mice in a cage with a wheel, they will run on the wheel. Not necessarily true of humans. If you're interested, this is actually a human crane. This is from a place called St. Rombolt's Tower, which was the tallest building in Europe for 400 years. And it was built by 8 blokes walking around on this wheel for 100 years, not the same 8 blokes, picking up very large pieces of masonry and sticking them up in the air. So what we've actually got organised now is really a continuous feast. We don't have any lack of food at any stage, and we've certainly managed to get rid of most of the physical activity out of our day-to-day lives. And that's probably the genesis of a lot of our diseases. So this is where the dietitians get annoyed with me, because they go, well, isn't it about calories? Do you think it's about calories? Do you think it's about what we eat now that's the biggest issue?
Partially.
Partially. How much of a partial do you reckon?
50-50.
No. So the person to read about all of this stuff is Stephen Blair. He's an American epidemiologist. And Stephen's looked very hard through pretty large databases out of the States. In the last 70 years, so since the end of the Second World War, our calorie intake has gone up by 15%. Now, the dietitians quite rightly would argue that some of the calories that we eat, it's not just about the volume, it's about the quality, and that's fair enough. But our physical activity level has gone down by 50%. So it's certainly very much on the PA side of things. And if you compare current with, say, some of the hunter-gatherer populations, we're probably doing less than 40% of the physical activity there. So they're still using their genome, and we're trying to make our genome something different. So we'll talk a little bit about some of the NCDs, and it's really, the more you burrow down into these various diseases, the more that you'll find there are effects on a sort of a macro level, a cellular level, micro levels, epigenetics. So I'm not going to bore the living daylights out of it. Well, probably am, but I'll try not to. So if we think about coronary heart disease, everybody here knows that physical activity's got an effect on coronary heart disease. 30% of all coronary heart disease and stroke can be stopped by people exercising regularly. But did you know that if you've got stable angina, you get better outcomes with 12 months of physical activity than having a stent put in for about a quarter of the cost? Now, the cardiologist, I annoy a lot of people, as you might imagine, but the cardiologist would go, yeah, well, we've got the stent in and they're fine now. That's true, but if I look at them at 12 months, the guys who did the physical activity program have better cardiac profiles than the guys who put the stent into for a quarter of the cost. Hypertension, there's a meta-analysis that looks at 44 different papers. If you look at people who are normotensive, the ones who exercise, their BP is about 2 millimeters of mercury lower, systolic and diastolic, than their non-exercising but normotensive colleagues. Big deal. If you look at the people who are hypertensive, the exercisers on average have a 7 millimeter of mercury drop over the non-exercisers. Now, you might think that's much, but if you need to consider then what's the cost of pharmacology to achieve that 7 millimeters of mercury, because that takes you out of the danger range and puts you into a safer range. So the average antihypertensive can cost anywhere between $30 a month to $90 a month. And believe me, there are a lot of people out there that are hypertensive. Congestive heart failure. Now you might think, well, you know, congestive heart failure, what's physical activity got to do with that? Well, 9% of all congestive heart failure is really just related to physical inactivity. Anybody want to guess how much hypertension contributes to congestive heart failure? 10%. So we rabbit on all the time about hypertension in congestive heart failure, but in actual fact, physical inactivity is as big a risk factor. And if we get people with moderate to severe congestive heart failure and exercise them, they don't drop dead, they get a 60% reduction in all-cause mortality. Dyslipidemias, I'm sure you know, if you exercise regularly, your HDLs go up, your LDLs go down, your triglycerides go down, and more importantly than all of that, your postprandial lipoprotein-rich triglycerides go down. Why are they important? Because they're directly related to atherosclerosis. All of the other things are kind of indirectly, but they're directly related. So we do our exercise, we reduce our risk of atherosclerosis. Other things that influence atherosclerosis, platelet function. So we get less clumping and we get less sticky platelets. And we don't actually need to be particularly active for that to happen. You can do 10 minutes of walking a day and you reduce that platelet clumping and stickiness. For people who've got vascular claudication, we know that if they start walking and they walk into their pain a little bit, and they keep walking into their pain a little bit, they keep walking into their pain a little bit, eventually they can double their walking distance. Now, you might think that's all important, but if it's the difference between being able to get to the pub and the TAB, it's very important. Type 2 diabetes, this is going to drive you guys nuts for the rest of your career because there's an awful lot of them. To a certain extent, I feel sorry for you guys because you are going to be, battling people with chronic disease your whole careers. And it's because the baby boomers have got older and they had a lot of fun. Right? But now they're paying for it. So if we look at the developed world, we're looking at 6 to 10% incidence and rising. If we look at hunter-gatherer populations, less than 1% incidence of diabetes. Now, it's a multifactorial disease, but if you are physically active, your risk of getting type 2 diabetes is 30% lower than the population average. There's some interesting work just come out that basically type 2 diabetes, we've got insulin resistance. So we keep pumping out insulin, but our insulin receptors say, nah, not interested. That same type of insulin resistance occurs just in the pre-pubertal region, so 9, 10, 11. And we know that if you exercise kids more when they're 9, 10 and 11, you knock down their insulin resistance. But they've now shown that if you do it then, the same thing happens later in life. So they get less insulin resistance 30 years later. That peripubertal period is really important for physical activity. I'll tell you more about that in a bit later. Now, look, there's an obvious relationship between physical activity or inactivity and obesity. And there's the sort of calories in, calories out, no fat people come out of belts and all those sorts of arguments. But it also has a lot of effect on a lot of the hormonal control of fat storage, things like ghrelin and those sorts of things. But one of the big disservices we've done to the population is to tell people who are obese and morbidly obese that if they exercise, they'll lose weight. They won't. Physical activity has no effect at the high end of obesity into the obesity range. They have to have surgery. They need to be physically active after that, but we just cannot shift that much fat. Asthma. We've been telling people for donkey's years that they have to do exercise if they've got asthma. Bad news is that exercise has absolutely no effect on normal, hyperactive, asthmatic airways. It does encourage kids who might have otherwise been sort of coddled because they get a bit wheezy to go and do stuff, because we know that that's good for their health generally, but it has no effect on their asthma. There is an adult onset type of asthma, gly-16 allyl asthma, which is rare as hen's teeth. If you give them physical activity programs, it cures 100% of them. If you happen to have chronic obstructive pulmonary disease, then asthma does not improve, physical activity does not improve your lung function, but it significantly decreases your perception of dyspnea. So it actually improves your quality of life dramatically, and it reduces readmission rates by 80% if you give COPD patients a physical activity program before they leave hospital. 80% is huge. All of those cancers reduced by 30% if you're physically active. I don't understand why. There are a lot of other cancers that are reduced by 25 or 30%. We know that physically active cancer sufferers have better quality of life indices and they have better survival rates. And it might come down to autophagy. Autophagy is where we get cell death. The body recycles some of the components of those cells. And we know that increased autophagy is associated with reduced risk of cancer. So we use more of the organelles, the mitochondria. So we reuse them rather than creating new ones. And we know that physical activity increases the rate of autophagy. Now, autophagy is not entirely benign. It is actually associated with an increase in some other diseases, but in the cancers, this might be one of the key drivers as to why physical activity has an effect. Musculoskeletally, if we look at osteoarthritis in particular, if you've got osteoarthritic hips and knees, 75% of everything we can achieve, we achieve by making you strong in the muscles and lose the kilos. Everything else is just fiddling around the edges. So we've got to keep it strong and we've got to get them to lose weight. For inflammatory arthropathies, again, when they're not in the terribly synovitic phase, physical activity is really important to them. So I had a patient who played netball for Australia who had rheumatoid arthritis. So I've got a cricketer who's played cricket for Australia who has psoriatic arthritis. I've just got another cricketer back from the Australia A team who's also got some form of inflammatory arthritis. So it's not a block to them performing at a high level. And for those of us who are just kind of mere mortals, if you have those diseases, it does seem that physical activity is quite helpful to them. Osteoporosis is a bit of a no-brainer. If we bounce around, then we have stronger bones. What's really interesting is if we exercise kids in just on that pre-pubertal, early puberty cusp, we increase their peak bone mass by several %. Now, you might think that's important, but we talk about the fracture threshold. Basically, the fracture threshold is when you push over 50 old ladies, half of them break their hip. So the longer it takes us to get to the fracture threshold, the better off we are. So having 2% extra bone density when you're 23, which is about your max bone density, means it takes you another few years to get to the fracture threshold. Given that we're all getting older, we don't want to get to the fracture threshold. 2% by doing a bit of activity when you're young, really important at the other end. So much so that British Columbia, again, this is one of Karen Kahn's inventions, they have a program called Bounce on the Bell. So when the school bell rings, everybody gets to hop for 2 minutes before they go into school. It's cheap. It's effective. It makes a difference. The trouble is, most of what we're talking about here makes a difference to people's health 30 years down the track. Politicians like standing in front of machines that go bing and have an effect tomorrow. So part of what we have to do is advocate and try and change the health structure and the political framework around health. We know that people who are physically active have less hip fractures because they've got more muscle mass, so they don't fall over as much, and when they hit the ground, they've got more padding, so they don't break as easily. Chronic pain, you probably haven't had a lot to do with chronic pain yet, but chronic pain is a major issue in Australian health these days. We know that physical activity programs assist people with chronic pain. A few other things. For general physical activity, we know that people's immune systems are better off. For elite level athletes, their immune systems are worse. They have real problems with the salivary IgA. It gets suppressed quite badly, which is why you see all the swimmers either get sick just before the world titles or immediately after the world titles. It's all to do with salivary IgA. We know that mental health is really important. So there's a little bit of tossing and turning about the effect of physical activity on depression, but on the strength of the majority of evidence, it is quite helpful. There are some studies that suggest it's as effective as SSRIs in the treatment of depression. Alzheimer's and other cognitive dysfunction, we know that physical activity programs have effect. So you've just heard me say physical activity 8 million times, fashion the same thing. Sedentary behaviour. Sedentary behaviour, Latin, someone who sits. And sedentary behaviour is a dangerous activity. You've probably seen all the stuff in the press at the moment about everybody needs to have a standing desk. that's just going to make me really busy with a lot of sore knees, ankles, and plantar fasciitis. Everybody needs to get up and go for a walk for 2 or 3 minutes. Just standing up is better than sitting down, but actually moving around is probably a bit better. And it's interesting, I just mentioned my mother passed away a couple of months ago. Now, my mother was ideal weight. She was in her early 80s, no health risk factors. She was hypertensive. She had bowel cancer. She passed away. My father, who is overweight but has had an active life his entire life, is 5 years
Where they've looked at the muscle quality and mass in 80-year-olds who have been regular weightlifters throughout their life. And what they found is they've got the same muscle quality and mass as the average 55-year-old. So we can probably delay this muscular decline by 25 years, just with some strength training. That's a big thing. There are other things that we can do in older patients. We know that older patients tend to have less high quality creatine intake. They don't eat as much steak because they probably can't afford it. Their appetites go down, but we know that creatine supplementation helps them, same as it helps swimmers and various other people. We know that weight control is really important because what I said before about fat is toxic stuff. It creates inflammatory proteins. Vitamin D supplementation. Old people's skin does not absorb vitamin D anywhere near as well as young people's skin, plus they go outside less. Vitamin D is critical to muscle health. Antioxidants, probably important. Things like N-acetylcysteine, really quite promising because we know that if we give it to older patients, they preserve their muscle mass a bit better. If we give it to them when they're strength training, they get greater muscular development out of the thing. N-acetylcysteine is quite an interesting substance. And then maybe targeted treatments like anti-myostatin antibodies. So, anyone know what that is? It's a big cow, isn't it? That's actually a Belgian blue cow. It's a particular breed that has a genetic deficiency of myostatin. Myostatin is what stops muscle development and increases fat storage. At the moment, WADA, the World Anti-Doping people, are really scared that somebody is going to come up with something that blocks myostatin. This same condition occurs in humans. It is extremely rare in humans. It also occurs in greyhounds and a few other things. But it's a big cow. Okay, so let's get back on track to the exercise part. So it's really important to understand that we're not looking for maximum fitness in our patients. Fitness, or the principle of overload for maximum fitness, means that sometimes we step over the line and we break things. And, you know, all my work with elite athletes is about people stepping over the line. I don't have elite athletes who undertrain, they overtrain, they break things. We don't want our patients to break things because we know that breaking things discourages them from being active. So we're not seeking maximum fitness, we're sending the message we're seeking to maximise health. And we can do that with much less intensity than if we're trying to maximise fitness. So aerobics, yeah, look, old doctor, got to quote Galen in here somewhere. So aerobic activity is simply activity that is rhythmic and continuous. And so we know that 10 minutes is okay, 2 lots of 10 minutes is better, 20 minutes is better than 2 lots of 10 minutes, and we know that intensity is important as well. Repetition in terms of times per week is important as well. So probably 4 to 5 times a week, starting at 20 minutes and aiming for 45 to 60 minutes. That's, if anyone likes bushwalking, that's Cryon Bay, which is right down the bottom of Tasmania on the south coast track. This one's hit a lot in the press recently, so sprint interval training or high intensity interval training. And that goes back to some research that was done by an Australian in 1985 and then kind of resurrected in the mid-2000s, early 2000s. And basically it says that if I get on an exercise bike and I pedal absolutely my guts out for 30 seconds and then have 4 minutes where I just rotate my legs and then do it again, and I do 6 repetitions of that, it has virtually the same effect on aerobic and anaerobic fitness as doing 45 minutes of aerobics. Now, a lot of what is put out there at the moment as HIIT or sprint interval training is not really, it's just a modification of the old idea of interval training, which means I'm going to run some 400s, or fartlek training, which is a Scandinavian thing where, you know, you run along here and then you run up a hill and then you go over there and vomit and then you run over there. The sprint interval training really is absolutely flat out. Now, the HIIT training is slightly nicer in that you don't have to go at 125% of your proposed VO2 max. You've only got to go about 90%, and you still only got to go for 30 seconds, but you only get a 2-minute interval. So there's good evidence for its effectiveness. What we don't really know is how far do we have this effect on all of the NCDs. We know that certainly in cardiovascular stuff it's important, but you know, if you've got patients who are time poor, getting them to do this once or twice in their week rather than another 45-minute aerobic session is an option. This comes from an ad from a clinic that does sprint interval training. I'm not sure I really want to be a cheater, but yeah. Strength training basics. I just break it down in really simple things, and I'm not trying to teach you how to prescribe anything much at the moment, but we need to do large muscle groups. We need to do both sides of the joint. So typically people would do chest, back, arms in one session, and a few days later they'd do butt, legs, and gut. And we have things like periodization that change the intensity. So if I'm looking to maximize my power, then I'm going to work at 2 rep max, 1 rep max. The idea of 1 rep max is simply what is the biggest amount of mass that I can move through a given distance once. That's 1 rep max. So really what we're doing for most people, we're trying to improve their endurance, not their absolute capacity. And so we'll give them something that's 20 rep max. In other words, I can do this 20 times before I'm knackered. And if we want to push them a bit, we might do 12 rep max. We don't start by giving them something that's really enormous and seeing if they can move it. We want to do closed chain, whole body work, things like squats and push-ups and those sorts of things. And 2 or 3 times a week is plenty. And our options, well, I often start older patients particularly using TheraBand. TheraBand is just stretchy rubber stuff. If you Google TheraBand Academy, you'll find about 8 million exercises that you can do with TheraBand. Then I move people into body weight resistance, so I get them to do chin-ups and push-ups or half push-ups or whatever they can manage. Machine resistance and free weights, those are things that people need to be taught to use safely. So they certainly do need to have a chat with a personal trainer or somebody before they move on to that sort of stuff. It's really important to remember that muscle gets bored. It gets bored after about 6 weeks. So if I'm just doing, if I'm training that range at that speed, I don't get any stronger in this range, and I don't get any stronger at that speed. So it's really quite specific. So every 6 weeks, you've got to vary your workouts. For flexibility, I like yoga and Tai Chi. Pilates is incredibly popular, but the research on Pilates is really unimpressive. It's prescribed for back pain all the time, 2 pilot studies, both of which say doesn't do good. So it's a case of marketing over substance. Stretching. Auckland University has been studying stretching for 25 years and they still can't tell me how long I have to stretch for or how often. It's a good program. When I want somebody to get looser in the hamstrings or looser in the calves or something, I tell them they have to do half a dozen stretches for half a minute every half a day. And if they do half that number, I think they'll do okay. It does seem that doing it twice a day is better than doing it once a day. Balance work. I know people don't think very much about balance, but there's a really elegant study came out 10, 15 years ago that showed that the more expensive your basketball boots were, the more likely you were to sprain an ankle. Of course, they'd taken all of your proprioception away because they were so padded and comfy. So old people wander around in slippers and all they ever feel is slippers and carpets. So we need to put them in bare feet and make them walk on the sand and make them walk on pebbles and these sorts of things. Balancing on a pillow, just standing on a pillow for 5 minutes a day, improves your lower limb strength by about 20%. So how do we increase our chances of success with these sorts of people? Adaptation. We've got to remember tissues adapt at different rates. Age. I've got an 80-year-old who holds 3 world titles in race walking. She can race walk for 20 kilometres. I've got a patient who's got a smashed up ankle who cycled the length of the Andes, not down at sea level either. And he got home and after a year he got bored. So he did a 3-month cycling tour solo through the stands. So he went through Kazakhstan and Uzbekistan and Afghanistan, Pakistan. It's got a very interesting blog. Much more success with exercise if we buddy up. So even if it's your dog, we've got to have a backup plan. If it's raining and you're a runner, you still need to be able to do some exercise. Having goals is really important. They might be health goals, they might be physiological goals, they might be, I want to be able to run the city to surf. Got to watch out for fads. Really good for my business. Every time somebody comes up with a new sort of activity, CrossFit's been fantastic. I have seen injuries I have not seen in 30 years of sports medicine in the last 12 months. Have a plan for injury because we know we're going to get injured. Novelty. Things like rock climbing, incredibly good for strength, proprioception, and flexibility. Things like ballroom dancing, incredibly good aerobic strength, really good flexibility, great for your proprioception. You need to know your personality. You need to know your dislikes. You know, if you told me I was going to die if I didn't swim, I'd go, I'm going to die. Dumbbells. One of the quickest tricks is to put dumbbells on the kitchen table. Do 20 dumbbell curls before every meal. It's an endocrine organ. It actually increases your muscles' capacity to absorb glucose. Hopping, for the reasons we said, hopping for old people has much more effect on their bone density than strength training or aerobic training. Equipment's simple. Milk bottles full of water, PVC pipe full of sand, footpaths, beaches. You don't all have to dress up in lycra, and your patients don't have to either. So I know I've gone a long time, but it's a big topic, and I hope some of it is something that you can think about and use. All right. So how about we do the hip exam, and then we'll talk about the hip exam. Now, if you want to do the hip exam properly to pass your exam, use the first link on the slides, which is the Oxford. If you go to YouTube and you look up hip exam, Oxford videos, that's the classic hip exam. If you can do that properly, you'll pass. Okay, that's not my hip exam, but it's what'll get you past. There are 7 videos from the British Journal of Sports Medicine which are available online that takes you through a more sports med-oriented hip exam.
Thanks.
Okay. So,
Do you want me single or jump side?
no, it's fine. So you're not going to see much up there, so you might as well come down.
Oh, well, that's it.
Yeah, everyone's the same except
So the basic principles of all joint exams in our system is basically goes back to Apley, and it's look, feel, move, X-ray. But kind of slightly more sophisticated than that. I say look, feel, move, and I have some special tests for any particular thing that I'm looking at. So the first thing in the looking part is just
make people take their clothes off. You wouldn't believe how many people I see who've seen 5 other positions. They go, oh, I'm going to take my clothes off. Well, duh, yes. I can't see much unless you go, oh, nobody else is going to take the clothes off. So, you know, you one up if you've got to take the clothes off. You start. And then we want to observe. I always observe people from behind, whether it's the shoulder exam or the hip exam or my foot exam first. And the reason is, if I don't, I forget. I tend to talk with the question. So I always ask them to turn around first, and the things that I'm going to look for immediately, I'm going to look at the foot posture. Right? Why am I interested in the foot posture?
But one leg might be short.
That's exactly how I know.
What if, well, officially off centre?
You know, I'm just looking at the feet. How can I tell what one leg might be on?
One might be on its.
One supinate, one pronote.
Yeah.
Or one might externally rotate the other stay neutral. But a quick clue straight away. You want to have a look at whether they've got good gluteal muscles. You'd be surprised how much you don't have gluteals, you can't stand up. So the old Trendelenburg that everybody talks about is really just weakness of glute medius and glute minimus in particular. We don't see that very much these days because we don't see people getting their gluteal nerves knocked off because the surgeon can be more careful. But we might see Trendelenburg just becomes more of an antalgic surgery. What else do we want to look at? So we've had a look at hip height visually. We also want to have a look at shoulder height because they might have a scoliosis. Then I'm going to get them to go for a walk. And so the classic antalgic gait is the shortened gait. And I've got to saw this one, so I put it down, but I don't keep it down as long as I keep this one. That's the link. Whereas the Trendelenburg is where I'm doing that. You won't see Trendelenburg, well, maybe you will in an example, you won't see it from one year to the next year. The next thing I get people to do is go for a walk. And I'm looking at things like stride length. Okay. I'm looking to see whether they externally rotate. If they're a kid, I want to see if they've got a limp. And the athletes I will actually go all the way a few times. The kids I will go. It's more dynamic, puts more load on the system. Okay, so coming back to the back end of things, I'll usually just stick my fingers on the grip. Put my fingers on the PSIS, and that just gives me a handle of where I'm at. And then I'll get them to stand on one leg. Just balance on one leg. If you've got an unsteady old load, you can still collect them. Stand on one leg on the other leg. And really what I'm looking here is kind of Trendelenburg's, but I'm making it harder to do. Okay. And now I'll get you to stand on one leg and tip backwards. And if that hurts under my thumb, that's the sacroiliac. This is the stalk test. Okay. Then I get people to sit on bed, just facing me. Go back a bit. So now I'm interested in very quickly figuring out what the sensation is. So I'll just get a pin on tissue and just bang, 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 bang. Because I'm looking to see, is the hip home around parastatic nerve, we've got something funny going on here, lingual nerve, genitofemoral nerve, femoral nerve. There's just all sorts of little things that pop up. So very quick to just touch people down that chain of nerves and go, yeah, that's all fine. Then I want to have a look at hip rotation. So hip rotation, classically people do it lying on the back. I do it 3 times. It's like so how much is the total rotation that I should have? Sorry.
That's all right. No, this one's good.
How much rotation should I have? Total hip rotation.
45 degrees.
90 to 100. For the average person, we've got a little bit more external rotation than internal rotation. What did we see here?
Yeah. So what's that mean?
Don't say that.
It means she's got femoral antigrowth. So the femoral neck is slight. That's important because it's associated with non-alignment syndrome when it's severe, not as bad. How about if I've got heaps of external rotation, not very much internal? That means I've got femoral neck protrusion. That means that my career as a ballet dancer is safe. But if I've got an anti-vertebral hip, I'm stuffed. I need to take up tactics. So we get information about what they can physically do as well as information about what their pathology might be. While I'm here, I tend to very quickly test power, so pushing out for me, pushing in for me, pushing out for me, pushing in for me. It's not in the textbooks, but it's a very quick way to screen goodness in all of the major muscle groups on both sides of the hip. Okay. I was going to push up. So again, we're looking at internal and external rotation. Got to remember that when we've got the hip in neutral, we might get a different picture to 45 flex. Because the capsule is much more in play when we've got the hip in neutral. So they may have capsule restriction. If it's a kid or somebody that I think has a fracture, all I'm going to do is log roll. Because if I've got a fracture, it'll hurt. If I've got a kid who's got a slip physis, they won't let me do it. If I've got a fracture, they'll probably be like this. They've got a short neck. I don't see many people with negativity, but I see lots of people who've got stress fractures. And they come into my sort of special tests. Another little one that you probably won't have heard of is the ligament teres test. The ligament teres is the thing that holds the femoral head to the acetabulum, carries 90% of the blood supply when they're a baby, and bugger all when they're an adult. But it gets torn and it can cause instability. So we bring them up into this sort of position and we're just rotating. And if that reproduces their typical pain, then I'm much more interested in ligament teres. If I'm more interested in the labrum, so the acetabular labrum, the cartilage around the bony acetabulum, I'm going to bring them up into flexion. That may reproduce their pain, or I'm going to rotate them. Okay. I'm going to rotate them and try and pick up the edge of the labrum to get a catching sensation that they recognize.
So internal rotation, or any rotation?
Yeah, because the labral tear can be anywhere.
Yeah.
It can be anterior, it can be lateral, it can be posterior. And some people will put them on their side and repeat the thing and put them on the stomach. But I'm just trying to reproduce their typical pain. So I've got to compress them. I'm just going to try and catch an edge. How about our Patrick test or failure test? What am I doing there?
Oh, I thought the favor was then dropping it down and then pushing down.
Yeah, figure 4. Yeah.
Yeah, figure 4, and then pushing it down, and then it's SRJ if it hurts behind, and then if it's groin, then it's hip, like intrinsic hip.
It's probably arthritis in most people because I'm not actually pushing much onto the labrum or the ligament teres in this position.
Okay.
How about if I go into theta? What am I doing there?
That was for femoral acetabular injury. Yeah.
Which, unless you're doing sports medicine, you won't ever see very much because it's to do with athletes. Basically, they do too much running when they're young. We get a little shift of the femoral head. We get a change in the head and neck angle, and now suddenly we develop a little bump that can jam into the acetabulum. Might horrify you. By the time a kid goes to the draft, to the AFL, half of them have already had major joint surgery, either a reconstruction or with FAI, they've had burring done to take off the excessive bone. The average kid who gets drafted to the AFL plays 6 games at AFL. So don't let your kids grow up to be footballers. or netballs. Not a professional level. While we're there, we talk about the ankle squeeze test. So squeeze your ankles together, and the knee squeeze test. Benjamin's up for me. Squeeze on that. If they are very weak with that, or it reproduces central pubic bone, then we're really talking about osteoitis pubis, which is a bone stress injury that is very common in running sports, not as common as it used to be. So there's our quick squeeze test. I don't really believe that stresses the sacroiliac joint, compresses the sacroiliac joint. So if I've got sacroiliitis, it's not. But if I'm worried about stability, and just pushing through on one side and stabilising the other side, or putting them on their side and pushing through, that loads the joint stability more so than its inflammatory bits. Okay. The sorts of things that I want to palpate while I'm there, and you see I'm jumping all around the place here. I want to know ASIS, what the catch of the ASIS. So that's it. Yes, because it does that.
Okay.
That teach you anything today?
It's all PC these days.
Yeah.
It probably is. AII,
Practice.
which bit? Okay, so it's the long head of rectus femoris, and the reflected head attaches to the ST bucket, and the reflected head is about twice as big as the long head. Much more important structure because it's really excited. In fact, does everybody do the essential anatomy of the if you haven't got it, it's like $12, really well spent. But one thing that they leave out is the reflected head rectus. We want to palpate the front of the joint, which is directly under the femoral artery. We want to palpate the lateral margin of the joint. And we want to palpate that bony structure. What's that bony structure?
Great.
Okay, so what's at the greater trochanter?
Yeah, that's up.
There are 7 verses in the greater trochanter. Most of the time they are completely irrelevant, even though people like sticking them in. The most common problem that people have with pain is that they get tendinopathy. It's really tensionised the hip. Most commonly glute medius, less commonly glute. We can also get issues with the iliotibial band. So if you roll that one,
Sideways or?
yeah, no, there's good. Okay, so the iliotibial band, just actually come back a little bit so we can space. Everybody familiar with Over's test for the iliotibial band? Over's test, we extend the hip and allow the leg to just relax. Okay, we try not to get the rotation involved, just let the knee. So some people, particularly runners, they're stuck up here. The ITB is so tight, actually, the TB. Therefore, the ITB is really tight, so they just can't. And if you find it's asymmetric, the other way of annoying the ITB is to stick your finger on it and just backwards and forwards, or do the same thing down at the knee, which is the most common place for the ITB. People who tell you that they can stretch their ITB, blowing smoke. The ITB is a thick rope. You could tow a caravan. Its stretch capacity is 2%. So we can't really stretch it. Maybe we can make it less reactive. Maybe we can make the TFL, which is kind of pulling on the dry rope, switch off a bit. We usually have to do that because the foot's not fine.
Does the rolling on the cylinder map over time help it to stretch as a therapy?
Okay. People certainly sold a lot of foam rollers. I wish I could. I've not seen any published data to say that it does anything that everybody loves doing. Because I've been doing this for a long time, I've seen an awful lot of fashions come and go. Athletes being athletes love to have something to do because really they don't go run around for 5 minutes. Okay.
Back over to that. So the other little test for the ligamentum teres is we're trying to get some posterior to anterior glide, so we get onto the greater anterior like that, and we push forwards. And sometimes you can feel laxing, sometimes you can feel this one a little more, and sometimes it just reproduces the tibia. Don't get too tied up with the teres, it's not a major pathology. Strict considerations and never other than that. What haven't we done? I'll think of it. But if you want to pass your exam, watch the Oxford video. One's and the sports medicine ones are really just more to help you out with athletes.
Can you could run us through just some of the other stuff like, like the leg length stuff and Galeazzi's triangle and
Who's triangle?
Is it Galeazzi's triangle?
No idea.
Okay.
Galeazzi's test for seeing where the leg length discrepancy is.
Okay, let me tell you that there is no validated external measurement of leg length. So it's all clinical impression, or you do a CT for leg length. And even then, 3 millimeters of discrepancy is within the error rate. So people get really excited about it. Over 10% of the population have got over a centimetre of discrepancy. I had a football player who ran around with 4 centimetres of discrepancy, and he didn't know he did until he was 26. So, I mean, Tasmanians are not necessary. So, look, what they would say is, lift the pelvis, get them to put it down, don't wriggle. Put your fingers on the inferior aspect of the knee malleoli. Is there a difference there? Yeah, I think there's a difference there. Bend your knees up for me. So, if I've got a short femur, this tibia is going to be further back than that one. If I've got a short tibia, this femur is going to be lower down. That's all. It's not rocket science, and it's not true. So even if you use a tape measure or whatever, you can't actually say that it's 2 centimetres or 1 centimetre. You can just say there's a discrepancy. But given that 10% of the population have got a discrepancy, who cares? But you can't relate it to the problem, you don't get excited about it. So a few golden rules about this. Every kid who's got hip pain has got serious pathology until you prove they have. Every kid who's got knee pain has got a hip problem until you prove they have. In the last 12 months, here is 6 months. Might have a pain here, they might have a pain here. But until you prove that with a stress fracture, they've got these sneaky injuries. The ones that happen up on the femoral neck, particularly on the superior aspect, can complete because they're on the, not on the tension side, they're on the traction side. So one's on the inferior neck or less line. I said probably 2 or 3. So the things we're looking for stress fracture, the hot test, that reproduces their pain, or the stress fracture. The hanging leg test, which is prescribed by David Humphries, who was AIS medical director for many years. So flex knee, push up for me, they give you pain. Good. And percussion is an old-fashioned one with custom through the but the hot test is the most reliable.
quite good for shin stress fractures. Okay. There's a talk on hip pathology if you're interested. I don't blame you if you're not.
Can you go through the knee exam?
A knee exam? Sure.
Are there any other kind of
Any other
exams
bits?
or anything people want to kind of go through? Just open it up.
So ankle would be good.
Ankle, shoulder. Because there's a couple of different ones. Yeah, wow.
Well, we can start at the bottom.
Yeah. I think let's go with shoulder first. Not because I don't think we should also go through knee, but I think it's one that 60s won't have really been taught before. Does anyone else have any other thoughts on that?
Okay. So again, I'll look up this to know what we have to do with the exam. My shoulder exam is based around the principle that I'm stupid and I can only think of three things, and the shoulder only has three things that I'm going to think about. Top bit, a middle bit, and the bottom bit. So I've got an AC joint, I've got a subacromial space, and I've got a hip. So the first thing you need to do is ask the patient to point to their pain. So if they point there, AC joint. If they point here, it's probably calf or subacromial space. If they do this or this, we'll start to get to their interest in looking at this. It's always good to ask the patient to point. They're really helpful. If they point back here, it's probably their neck. So they're nothing to do with it. But again, it's look through a move X-ray. So we want to have a look at their stance. We want to see whether their shoulder is symmetric. Always start at the back because most of the muscle relationships occurs in shoulders. We want to see whether the traps look okay. We want to see whether the rhomboid look okay, and particularly we want to see whether there's wing either just passively or reactively. When I'm interested in range of motion, I just ask them to touch at the back, which is combined internal rotation. It's not a very accurate measurement, but they should be relatively symmetric unless you have to be a baseball pitcher, in which case they're very symmetric. Then I'm going to get them to lift all the way forwards, and most importantly, as we do that, we want to have a look at what their strength is. Because their strength really shouldn't move until we've got about 60 degrees of elevation. After that, it has. Same thing with abduction at the top. You're a bit asymmetric there, aren't you? Got some nice scars there too. Something happening there?
A couple of things, yeah.
Okay, so again, I examine their strengths from behind. And while I'm at the back, I'll still do their sulfur side. So I don't do things in the classic order. I do it because of where I'm situated geographically. So sulfur side, just pull down. I'm looking to see whether there's a step here, because that's a sign of multi-direction. And a good measure, I'll just go over and front back. Okay. Then I'll turn them around, and I'm particularly interested in their range of external rotation. Why? Yeah, it's the most sensitive indicator of human. So if they've got global loss of range of motion, there are only two conditions to give you global loss of range of motion in the shoulder. Disease of capsulitis and osteoarthritis. End of story. So, it's a lay down. What else do we want to know about doing that human joint? It's stable, and its stability is a combination of things. It's the shape, it's the collagen, and it's the muscles. So we've already discovered that you've got stretchy collagen, and we've already discovered that we've got some holes in there. So we know that you've got some things in there. Yeah. So that's your cuff repair. And these ones if you don't like it. Strength testing. So if I'm testing outwards, what am I testing?
Infra.
Infra, yep. Inwards, subscap. up here.
Superstars.
Yep. Anything else on that test?
Strength, you can do like adduction as an internal control.
Anything else?
There's also, I thought for subscap, people do like the lift off
Yeah,
test.
you can
or
use a
the-
lift on test, which is just that.
Yeah.
Doesn't matter so long as you just keep in mind that you've got three muscles there that you really want to test. Testing pec strength is really useful. Still put the strength is occasionally useful. They've got wasted rhomboids or something like that. I'll figure out how you can test that. The classic test for labral structures is a Ryan's test. So push up, does that cause pain? Push up, does that cause less pain? And when it was first reported, it was reported as having a sensitivity and a specificity over 90%, but really it's not possible because there are no clinical signs that have it. It's kind of been subbed down to about 70%. The other thing that is positive with this sort of test, what do you reckon?
Long-head biceps.
Yeah, but the long-head biceps is inserting into the labrum, so
That's still slight.
that's the same thing. What's the other thing?
So that's
Impingement.
AC.
AC, yeah.
big
So-
cross-arm test as well
That's-
for that.
That's right. Start with. So really, we need to ask them where their pain is, really, because if they go it's there, then that's different to if it's there. Yep. Well, we've got the basics out there. We're really just looking at undulation, what's good, what's not. We want to check the stability in the shoulder. So stability is down, forwards, backwards, and the apprehension containment test. Is that happy with that?
Do you think you can show us?
Sure. So have them on the side of the bed. The other thing is watch their face, not your hands. And as soon as they start to move nerves, you go, you worry about that? Yes. Is it better if I do that? Yes. Posterior instability. You can also do good for labral tears by doing this sort of activity. Long-headed biceps is trigger and similar. Got the classic sort of speed test. That really allows.
Do you have a comment on, so you know, like there's the classic the MTB can test for supraspinatus, but then another.
Everything activates with every resistance test. It's just that some are more vulnerable to showing weakness in those particular conditions. Impingement tests, which one is it we going for?
It's Hawkins.
Which are
So one will be externally rotating, the other one will be internally rotating.
Sort of. But all impingement tests work on the principle that the humeral head is not a sphere, it's a football. And if you can bring them into internal rotation, then you bring them on one axis. Same would happen if you take the pull like this one. The internal rotation is easy. So internal rotation, does that give you pain or does that not give you pain? And what kind of modification the crank test is just to, try and make people secure. Does that give you pain? And the beauty of this is I've actually taken into different positions. So we're really just making the most of the fact that it's an asymmetric object that can make things uniform by putting certain positions.
So which one of those two impingement tests, the last one, was that Mears or Hawkins? Or like with a modification?
My recollection is this is Mears and
That
this
was
is, it's actually the crank.
Crank test. Okay.
I think you just need to be able to demonstrate one and name another. It should keep any exam happy. Anything else about shoulders? There are lots of other things
Yeah.
to look for, but really the guts of it is you need to know what space am I testing, what area am I testing, and what are the most common pathologies that I ask.
So what would you think would be the most common pathologies that we might get in an exam for a shoulder?
Yeah. So if you've got an old person, you're looking at capsularized or arthritis. If you've got a young person, you're probably looking at coincidentally.
Yeah.
So, you know, a big part of sports medicine is actually thinking about what age would the right feel. So I said, at the moment I've got 2 patients in their 90s, and we're just trying to keep them physically active so they can stay out of the home. And I've got patients who are 6. Parts of our practice are getting more and more like old gym physicians. So sports physicians with a half an hour.
You might be able to just, like, I've never been taught how to examine an ankle, and I know that we can get within our exams.
Okay.
So just a very quick run.
No, same time. You want
So
to
you
look.
get rid of my.
No, you never got time. So we want to observe. We want to get you to roll out. We can't roll out. This is the light foods we have to see the somebody as well. Get you to pull your toes up, right, so we can see all of the toe extensions, the HL, the elbow, we can see it's your hand. That's away from the, we're looking in here because we're particularly interested in tibialis posterior. So tibialis posterior, the most important thing in the ankle, even more important to us. Tib posterior is what stops us going past spinal valgus. If you stay in past spinal valgus, eventually you will stay. People cope with rupture if you lose that. The classics for tibialis posterior is the 2 mini toes sign, because they move into the past spinal valgus. When we look at them from behind, we can see more toes sticking out. And the other thing is you get them to rise on tiptoe. So 1 leg at a time. If you've got a dysfunctional tib post, you can't do that because it only requires a really small amount of stretch before it loses the mechanical damage of running around the organs. So here are our kind of observation things. And one other thing that's really important in athletes to test their proprioception. So the quick one is down on 1 leg, unlock your knee, close your eyes, tilt your head back. And if they're still standing, their proprioception is not too bad. Because we're just progressively knocking out the bits of the sensory system. We're confusing them for years. We're maybe longitudinal fasciculus out. Now, again, we want to sort of break it into what sort of areas of the body in the ankle. Well, you still filiotibial. That's important because we know that they have that 4 times as long as other first ones, and they have positive Chelsea test. So you squeeze them up here, for example. The talus is not a rectangle, it's wider at the front, so if we push them back and that reproduces the pain, that's because we're spreading the ankle. But you know, really what they want for a basic exam is, can I examine the which is the draw test. So, draw test. I've got small hands, so the only way I do things are really with small hands. But I'm just going to anchor one side, and I'm going to pull the other side forwards. And I'm looking for tibial translation. Yes.